This is option B, Human Musculoskeletal Anatomy. And we have the fairly typical view of bone. And I think everybody was happy. Haversian canal being X, these little canals in the middle. From every bone picture in every textbook. And what are they for? Well, we've got kind of living tissue around these, and living tissue requires all sorts of things, like oxygen, needs to get rid of CO2, needs nutrients. There'll be nerves that run through this as well. So it's rolling bone, blood supply, so to supply oxygen to cells. State the percentages of organic and inorganic. This is just from your notes. You should know this. And it wanted the exact numbers, 30 and 70. Again, most people were happy with that. And here's some blurb. Now remember, you can't just repeat the blurb in the answers. You need to interpret it somehow. And it says, bones lose minerals and gain minerals and remodel, reshape. And as we age, you tend to lose more than you gain, and that's osteoporosis eventually. All of these treatments here, they all lead to a gain in bone mineral density, and they all reduce fractures, but by differing amounts. And we have our drug denosumab, great name, and it binds to these cells and inhibits them. What job have we got to do with reference to the mineral composition of compact bone? So we better mention that. And the cells found. And describe how bone remodeling takes place and suggest how denosumab can be used. So those are the jobs it wants us to do. So let's talk about these cells and how they affect the minerals. So we've got our two types of cells, osteoblast, and we've got osteoclast. So we've mentioned the cells found, and we need to talk about how they affect the mineral composition. So osteoblasts, they secrete the matrix. And osteoclasts, they kind of break the bone down, or words to that effect. So break bone down. So we've explained what these two different cells do. There's 4 marks available here, and we need to now talk about this drug denosumab. And what do we think it does? It says it inhibits osteoclasts. So that we can't get a mark just for repeating that, but we need to say the effect of it. And so it means that now, instead of, for older people, instead of bone being broken down faster than it's secreted, it's now secreted faster than it's broken down. So less bone breakdown. Or we could say that the osteoblasts are now more active than the osteoclasts. Osteoblasts more active than osteoclasts. And we could give some data here, suggest how it's used for treatment. Well, why it's used for treatment. This last mark is not really, it's on the mark scheme, but it's not really asked for in the question, but it's a mark, and it's really saying that bone mass density increases or fractures are reduced. So using the evidence that's given in the table. So bone mineral density increases and less fractures if you use that treatment. Well, a bit naughty that last word. With reference to the data provided, that must be this data here. Conclude whether denosumab or estrogen is the most effective treatment for osteoporosis, and give a reason for your answer. So 1 mark is for just saying the name of the drug. That is either that one or that one, and we're going to go into compare denosumab with estrogen, and there's a kind of clear, there's not much difference in bone mineral density gain, 3 to 6% as opposed to 3 to 5, but there's quite a big difference in fracture reduction. So that's the one that we'd probably go with. So choose a drug, denosumab, that's what we're going to go with, and then we're going to say reduce the fracture by 55 to 70%, as opposed to estrogen only reducing it by 35%. So reduces fractures by 55 to 70%, whereas estrogen only 35%. Part D, here's a fractured wrist. Now, all sorts of answers you could give here, pinning and surgery and all sorts of things. With this type of fracture, then you see people, you see lots of people with casts on. So what they do is just line them up and put the cast on to immobilize it, and that's really it. So for most people who break their wrist, they don't go down the screws and rods and things like that. It's not severe enough for that. Because it will hold together with a cast. So realignment, or words to that effect, and then immobilization with something like a cast or splint. Other possibilities, you could say pins or plates, but probably not severe enough for that. Now we've got some more blurb. Osteoporosis, and we've got a scan report. Lots of data here. We don't actually need to review all of it, but we can calculate a T-score. And really what they're trying to test is can you get data from a table and calculate something with it. So here we got a T-score to calculate. So patient mean BMD. So there's our BMD. There's the mean, so we are going to use that. So that is 0.759 minus young adult mean bone mass density, that's that one, minus 1, divided by standard deviation young adult BMD, that's that one there, 0.1. So 0.1. And when you do that, 0.759 minus 1.0, and then divide that by 0.1, is minus 2.41. So minus 2.41. Then here's a graph, and we've got our t-score here on the left, and so we're trying to interpret our t-score, and we are looking at this graph. This graph starts at 0 at the top and into negative numbers. So actually 2.4, there were some errors reading the graph the wrong way. But 2.4 is between 2 and 2.5, so you can have a sort of reality check. And then we have the age. What age shall we use? The lumbar scan of a 60-year-old woman there. So we are 60. And so this is our point on the graph to read. So diagnose her condition and the fracture risk. So this appears to be the fracture risk. So fracture risk, and we'd say moderate. So moderate fracture risk, and the condition 2.4 again. 2.4 is there. Osteopenia. Osteopenia. So it's reasonably straightforward math skills. And then part E, arthritis, affects joints, particularly those in the hand and wrist. Compare and contrast the structure and movement of the wrist and finger joints. So there's 4 marks here. So we think we need to talk about these 2 joints and how they move. And it doesn't actually say what type of joint, so I'm going to say what type of joints they are. It doesn't say name, but it would be a sensible thing to do. So we've got wrist and we've got finger. And most fingers, you can't bend them sideways, you can only go sort of up or down, so we need to describe that sort of movement, whereas wrists can do all sorts. They can move in up, down, left, right, sideways, diagonally. So these are all planes of movement. So one plane, lots of planes. So our wrist is a gliding joint, whereas our finger is a hinge joint, and our finger just has one plane of movement. Or words to that effect, just moves up or down, whereas our gliding joint has many, or a wide range of planes, so moves in more than one plane or a range of movements. And finally, the patient presents symptoms of pain, stiffness and swelling, increase in temperature, swollen. Okay, and this is for arthritis. So we need to choose, is it osteo or is it rheumatoid arthritis, and then explain our conclusion for another couple of marks. Well, these sound very much like rheumatoid arthritis. And we're going to give our explanation. Well, what do we know about rheumatoid arthritis? It's an autoimmune disease. And we can't get any marks just for repeating these points. We need to explain why we're getting pain and stiffness and swelling, and that's the inflammatory response, or the body sending lots of blood to the joint. So our inflammatory response, sending blood to the joint, whereas that wouldn't happen with osteoarthritis. It's just the kind of grinding of bone on bone, really. And that's your 20 marks for the option.